Hi everyone, welcome back to our Facebook Live series where we tackle different topics related to breast health, breast cancer, and the work that we do at Susan G. Komen. I'm Katharina Kang, the Mission Programs Director for Komen, North and West Texas. As a reminder, you can catch all of our past videos here on our Facebook page in the video section or on our YouTube channel. Just search for Komen, North and West Texas. This month we'll be discussing breast cancer treatment, specifically systemic therapy or adjuvant therapy. Since we're talking about breast cancer treatment, we want to remind everyone that all people and all breast cancers are different. So treatment paths can also be very different from one person to the next. After a diagnosis, your doctor will put together a recommended treatment plan. We encourage you to take the time to study treatment options in order to make thoughtful, informed decisions. Ask questions. Your doctor should take the time to answer any and all questions and concerns you may have before you pick the treatment option that is right for you. Breast cancer treatment is divided into two general categories: local therapy and systemic therapy. The goal of treating early breast cancer with these therapies is to get rid of the cancer and to keep it from coming back, but the way in which they work is different. Local therapy removes the cancer from a limited area, such as the breast, chest wall, or lymph nodes in the underarm area. Local therapy involves surgery with or without radiation therapy to the breast area. Systemic therapy, also called adjuvant therapy, which is what we are going to focus on today, is an additional therapy your doctor may prescribe after localized therapy is complete. While local therapy works to remove cancer from a specific area and keep it from coming back in that same spot, the goal of systemic therapy is to get rid of cancer cells that may have spread from the breast to other parts of the body. These cells are too small to be seen on scans or to be measured with lab tests. Systemic therapy uses drug therapies that travel throughout the body to get rid of cancer cells. It includes chemotherapy, hormone therapy, and HER2-targeted therapy. Some drug therapies are given by vein through an IV, and some are pills. Because systemic therapy is used in addition to or an adjunct to breast surgery, these treatments are called adjuvant therapy. Let's start with chemotherapy. Chemotherapy drugs kill or disable cancer cells. The decision to use chemotherapy is based on the tumor stage and certain tumor characteristics such as hormone receptor status, as well as your age, overall health, and personal preferences. For those with early stage breast cancer, chemotherapy is usually given after breast surgery, but before radiation therapy. Adjuvant chemotherapy helps lower the risk of breast cancer recurrence by getting rid of cancer cells that might still be in the body. In some cases, chemotherapy is used before surgery. This is called neoadjuvant or preoperative chemotherapy. In women with large tumors who need a mastectomy, neoadjuvant chemotherapy may shrink the tumor enough so a lumpectomy becomes an option. Additionally, women with inflammatory breast cancer usually begin treatment with neoadjuvant chemotherapy. The next type of adjuvant therapy is hormone therapy. Some breast cancer cells need estrogen and or progesterone, hormones in the body, to grow. Hormone therapy slows or stops the growth of these tumors by preventing the cancer cells from getting the hormones they need to grow. All tumors are checked for hormone receptors. A pathologist determines the hormone receptor status by testing the tumor tissue removed during a biopsy. Hormone receptor positive tumors have a lot of hormone receptors. Hormone receptor negative tumors have few or no hormone receptors. Hormone therapies are only used to treat hormone receptor positive breast cancers. Most breast cancers are hormone receptor positive. Hormone therapy is usually given after surgery. In some postmenopausal women, hormone therapy may be used before surgery to try and shrink a tumor enough so a lumpectomy becomes an option to mastectomy. This is called neoadjuvant hormone therapy. Our last form of adjuvant therapy is called HER2-targeted therapy. Some breast cancers have high amounts of a protein called HER2 on the surface of the cancer cells. The HER2 protein is an important part of the pathway for cell growth and survival. The HER2 status of a tumor is determined by testing tissue removed during a biopsy. All newly diagnosed breast cancers are tested for HER2 status. If the HER2 status is positive, treatment will likely include HER2 targeted therapies, which kill HER2 positive cancer cells with little harm to healthy cells. About 10 to 20% of newly diagnosed breast cancers are HER2 positive. One form of HER2 targeted therapies is called trastuzumab or Herceptin. It is a specially made antibody that targets HER2 positive cancer cells. Trastuzumab attaches to the HER2 protein on the surface of HER2 positive cancer cells, which can slow or stop their growth. For women with HER2 positive early stage breast cancer, chemotherapy plus trastuzumab cuts the risk of recurrence in half compared to chemotherapy alone. Trastuzumab is given by vein through an IV or by injection every 3 weeks for 1 year. It can also be used to treat HER2 positive locally advanced and metastatic breast cancers. We've covered a lot of information in today's topic. Don't worry if you've missed any of it. You can find out more about adjuvant therapy on Komen.org. There's more information on adjuvant therapy, including treatment side effects and management, emerging areas in breast cancer treatment, and clinical trials. This month, we are spotlighting Kathy D. Miller, MD. Dr. Miller is the Balve-Lantero Scholar and Professor of Medicine in the Division of Oncology at Indiana University School of Medicine. She also serves as a co-leader of the breast cancer program at the Indiana University Melvin and Bren Simon Cancer Center. Dr. Miller focuses on testing new therapies for breast cancer patients through clinical trials. Dr. Miller's Komen-funded grant studied a new treatment regimen for triple-negative breast cancer patients, combining chemotherapy and a drug activity inhibitor that causes DNA damage leading to cell death. This will help to identify patients who will not respond to common therapies. Through this lens, Dr. Miller and team measured the impact of various treatments like surgery, radiation, anti-estrogen drugs, and chemotherapy during the first year of diagnosis. They found patients were not as physically strong at baseline than anticipated, and that muscular mass and power declined during therapy. Her current Komen-funded project uses a novel physical training technique to help breast cancer patients. The technique was initially developed to assist astronauts returning from long-term spaceflight and is based on the principles of blood flow restricted training. You can learn more about Dr. Miller and the rest of our Komen scholars at Komen.org/meetourscholars. That's it for this month. We hope you have a wonderful holiday season, and we'll see you next year.